Okay, thank you. Why don't we get started? My name is Bill Pat Jane. I'm the Executive Director for the American Parkinson's Disease Association Massachusetts chapter. Welcome to today's presentation. The APDA of Massachusetts has been in operation for decades and offers programs and services to the PD community in Massachusetts and surrounding states. We've gotten a very large response for this presentation. It will be recorded and it will be up for viewing down the road. Just a few things. There has been tremendous progress in the understanding of treating Parkinson's disease recently. Parkinson's disease is highly individualized from person to person, and not all that is discussed today is relevant to everybody. The healthcare team must be familiar with the signs and symptoms of Parkinson's disease, treatment strategies, and how PD impacts the individual patient. Treating PD well requires a team approach. Today we are providing information and it is not intended as medical advice. I'd like to introduce Dr. Ludy Shih, MD. She is the Director of Deep Brain Stimulation Program at the Parkinson's Disease and Movement Disorder Center at Boston Medical Center and Boston University School of Medicine campus. Dr. Shih is board certified in neurology and is fellowship trained in movement disorders. She completed her neurology residency and movement disorders fellowship at Harvard Beth Israel Deaconess Medical Center. Dr. Shih is the director of Deep Brain Stimulation Program and is actively engaged in teaching, patient care, and clinical research. Today's participants will learn the latest on deep brain stimulation, DBS, as a treatment for Parkinson's disease. As we move through this presentation and at the very end, we'll take questions from the chat box. And so without further ado, I'd like to transition to Dr. Ludy Shih.
Thank you, Bill, and thank you to Rosemary and Kathy, who are also organizing this webinar on behalf of the Massachusetts APDA. I'm really pleased to be able to speak with you all. I'm just going to make sure everyone can see me on video. If someone could just let me know that that's the case. Great. Excellent. Thank you. All right. I'm going to move through the slides. Here was the introduction so nicely given to us by Bill, and want to really highlight for you what we'll be talking about. I'll leave plenty of time for questions in the chat box. Now, a lot of what I'll be talking about is what's new about deep brain stimulation for Parkinson's disease, but we'll start with some of the basics as everyone may have different levels of familiarity with deep brain stimulation in general. So we'll talk about really the basics of PD at the very beginning, very briefly, what deep brain stimulation is, and some of the new DBS technologies. Why do we even need them? And what do they actually mean for patients who are considering this? Finally, we'll really talk a bit about the role of a multidisciplinary team, which is should not be a novel thing, but it is clearly an innovative way of delivering care, and I think an important way of delivering care, especially as it relates to deep brain stimulation. And we'll have a list of further resources for you to look at even after this webinar is over. And as Bill mentioned, I won't read verbatim, but again, a reminder, any medical information I'm talking about here is really for providing information. It's not specific medical advice. For this, you really want to engage your healthcare professionals for this. Some of my disclosures, I have some grant support from the National Institutes of Health, and I have a few consulting agreements with the following companies listed here. So what is Parkinson's disease? I think many of you are aware, but let's just get on the same page with some of the language. It is a disorder of the nervous system, not just the brain, but of the entire nervous system. And it can affect a person's ability to perform a lot of common daily activities. It causes both motor symptoms, which really entail problems with moving, but also non-motor symptoms. And some of these include sleep problems, constipation, mood problems such as anxiety and depression, fatigue, among others. The motor symptoms related to Parkinson's disease are largely due to lack of a brain chemical called dopamine. And that is the basis for a lot of our medication treatments. But it turns out that motor symptoms aren't strictly ameliorated by dopamine and can be improved by other techniques as well. We'll talk a little bit about deep brain stimulation. So to review, some of the classic motor symptoms of Parkinson's disease are tremor, which largely occurs at rest, but can also occur when you're holding your arm or up in the air. It can also affect the leg or the jaw as well. Rigidity really is felt by people as stiffness or sort of an inability to relax certain muscles, often on the side of the body where the tremor or the slowness is most apparent. And bradykinesia is the medical term for that slowness, which can be experienced by patients in a lot of different ways. It may be just a single hand or arm, it may be a leg, it may be the whole body that feels slow. Postural instability, finally, is that fourth so-called core symptom of Parkinson's disease, which entails problems with balance, but often for people doesn't occur in a major way until later in the disease, but it can occur earlier on as well. And these are things that we counsel patients to look out for and examine for them in the clinic as well. Finally, a fifth symptom that we'll talk about because it's important when thinking about deep brain stimulation is dyskinesia, and that's the medical term for disordered movement, which are really involving involuntary movements. These are excessive movements. They can look like dancing or fidgeting. And one peculiar thing about them is sometimes the person with PD themselves may not realize that they're having them. They are often as a result of being on medication, usually dopaminergic medication like levodopa, which can be both a good sign and a bad sign. The good news is it means the medications have worked well and usually given the patient more freedom and ability to move. But sometimes that comes with the involuntary movements, and sometimes those are bothersome, and people would like them to be stopped or helped. So an important other thing, which is not a motor symptom itself, but more about how and when the motor symptoms are most apparent during the day, is a concept that we call on time and off time. And as some of you know who are already on medication, some folks at the beginning will take their medication as instructed by their doctor, and maybe it's 3 times a day at first, and they don't really notice a big difference from morning to night how that medication works. They just know that in general, the medication has helped them move better, maybe have less tremor, maybe have more ability to do their daily activities. But as time goes on, and in certain patients, which seem to be more prone than others, you might take a dose of your medication, which we've sort of borrowed this figure from a nice review article. Let's just say when you take your medication here, this is sort of how much of the medication enters your bloodstream after about 10, 20, 30 minutes. And you're in a good spot. It's this good white space here where you're feeling good, you're feeling on, you're able to move. But then you notice that you're starting to slow down. Things get more difficult. It's more difficult to get up and out of that chair. Your tremor may return. And that's when presumably your blood levels, but more importantly, probably your brain levels of dopamine have dipped because it's been several hours now since that last dose of medication. So much of the time, people spend good time in their good on response might be pretty large and pretty long early on. But as time goes by, after years of disease, people will notice both that the on time, there's less of it, your blood levels may even remain the same, but the brain's response to the same amount of medication is just less and less with time. And in addition, you may also get those involuntary movements. So you're spending time, you're turning on, so to speak, as your blood levels and brain levels rise. For example, you may get a little involuntary movement, but then as time goes by, that seems to get better. But then also you may, quote, wear off again. And in some folks, this window where they have this nice on time is really small, and it becomes smaller and smaller and really much harder to keep up with the kind of medication regimen that they're on. So, what is deep brain stimulation and how does that fit into the therapeutic picture? Well, first of all, DBS is actually a therapy. It's not just a surgery, it's actually a therapy that uses electrodes implanted surgically. They're placed deep within the brain to actually deliver the electrical impulses to some of the important brain structures that are needed to improve PD motor symptoms. The electrode is also often called the lead. There's another piece of equipment that's really important. This lead is then connected, I'll use my mouse here, to a pulse generator, which is just a fancy word for a battery. And it's implanted under the skin. So sometimes we abbreviate it and we'll call it the IPG, implantable pulse generator. And this battery powers the lead to deliver the electrical stimulation 24 hours a day, 7 days a week. And these aren't electrical impulses one can feel necessarily. They're delivered at such a microscopic level at a very high frequency. You don't have sensation here deep in the brain. You wouldn't feel those impulses there. But what they do is normalize some of the brain circuit rhythms that are abnormal in Parkinson's disease. And they relieve some of that tremor, that slowness, that rigidity, and the dyskinesia that I alluded to in the earlier slide. Here's a magnified view of what an electrode looks like. And I want you to think about this because in the subsequent slides, I'm going to show you some technological innovations that have changed the way some of these leads look and potentially how they change some of our ability to deliver good deep brain stimulation therapies. And then over here on the right-hand side is a programmer, which now looks like a tablet or an iPad for most clinicians or most doctors doing the programming. I will show you some examples of a patient version of this. Now patients have the ability to do some adjustments on their own with some clinician supervision. And we'll take a look at a few examples at how technological innovations have made some of this a little bit more user-friendly. So let's talk a little bit, though, about some of the historical innovations in DBS, or more broadly, neuromodulation. DBS has actually been available to patients for almost the last 25 years. Even though we think of it as science fiction sometimes, it really has been one of the oldest approved therapies for Parkinson's disease compared to even some of the newer drugs that we have available for PD. And in 1997, that's when the FDA, the Food and Drug Administration, actually approved DBS for tremor related to Parkinson's and both essential tremor. And then a few years later, also made that approval extend to some of the other motor symptoms of Parkinson's disease, like the other ones I was talking about, more for advanced PD. And the reason this came about, I have a few pictures up here, and for those of you who may be interested, a lot of this came about because of cardiac pacemaker work, and also because of innovations in trying to deliver similar sort of neuromodulation therapies for people with chronic pain. Originally, some of these earliest devices were actually powered by plutonium. This is actually a radioactive symbol that you can see here. And we needed a better way to make sure batteries can deliver energy over several years, because this thing resides in someone's body, yet it still has to deliver energy. The middle picture is actually a cardiac pacemaker. You guys will notice that this looks actually very similar to the items on the right, which are deep brain stimulation systems and pulse generators for DBS systems. I'm using just Medtronic here as an example, just because they have been the company that have been in this space for longest. So they have some of these devices that I could show you historically over time. But the other companies that make DBS devices now will have very similar looking pulse generators or batteries. So for a while, this took us, quite a while. After 2002, not much visible was going on in terms of modifying or changing some of the DBS therapy. But there were a few studies done in the 2010s that seemed to give us information that maybe instead of just advanced PD, offering DBS sort of as a last resort, it might actually be effective and maybe even more effective in people who are just a bit earlier in their disease. And a few pivotal papers came out, one showing in a group of centers in Germany and France that patients who had had Parkinson's disease for at least 4 years, but were having the same motor complications, the on and off, and the dyskinesias that I was telling you about in the previous slide, that DBS seemed to work very well for them, and to the extent that it improved their quality of life in comparison to a group that was sort of randomly assigned to get just the best medical therapy, medications only. And so the FDA expanded and approved the use of DBS for people with Parkinson's disease with at least 4 years duration of disease. And finally, in 2016, too, some of the technologies had started to show that they could also be useful in clinical settings. And so FDA approved two things that I will talk about a little bit more in the next few slides: directional DBS, and there are a couple companies who make those, Abbott and Boston Scientific. And sensing DBS was approved just recently, last year, and we'll talk about that. And that is something that Medtronic so far is the only one that offers. So, why do we even need all this advanced DBS technology? It's one thing to go over, hey, here's the latest and greatest, but we all think that we all know that we want to take new technology into consideration only when there's a need. In this case, it turns out there are some needs that some of these technical advances address. The first one I'll talk about, it underlies a lot of what neurologists and neurosurgeons spend a lot of time thinking about when preparing someone to go through DBS surgery and therapy. And that is that precision is important for clinical success. We'll talk about some of these other items as we progress through the slides, but let's talk about precision and what that means for DBS technologies. Here I have for you a couple of pictures of the brain. Imagine this is just sort of a cross section where this is a person, you're looking straight at them, and you've got the two lobes, the right hemisphere and the left hemisphere. And deep in the brain, in the sort of highlighted in different colors for you, are some of these anatomic regions that neurosurgeons and neurologists treating PD patients with DBS, that's where we like to think about where to put the electrodes. And these are what are approved by the FDA. And the most common one is the subthalamic nucleus. Another one that's also approved in general is the globus pallidus. And it's the actual internal versus the external portion of it. That's why it has this little I denotation here. And those are the two that we predominantly talk about for Parkinson's disease. And what DBS actually does is it actually modifies electrical circuits that control neurological function. So your circuits are so tightly packed in here, and they're very complicated. We still don't really completely understand how these circuits work in the brain, but a lot of science has advanced in the last several decades that help us understand really how deep brain stimulation works. But a lot of that groundwork and that foundational work was laid down when it was discovered really that by sending a small electrode by which you could listen to the brain neural activity, that is, a single neuron acts as a little spike of electricity. And you can actually hear this by sending a listening electrode down into the brain. And it turns out that a very particular area of the brain is so important for alleviating those DBS symptoms. And here I've depicted it in a cartoon here. And that's the subthalamic nucleus. And it gives off a particular sort of sound because all the cells in that region tend to be acting with a certain activity rate that we can recognize as really being of that important area. Now, this important area, the subthalamic nucleus, is the size of about a Rice Krispie. So it is small. And so having your electrode that delivers therapy as close to it in it, as close to being right in the sweet spot as much as possible, that's going to be helpful for success. But aside from that, these other structures of the brain, they do things too, and I haven't labeled them, but if you are a little bit off, 1 to 2 millimeters off, more than that, even 3 to 4 millimeters off, you might deliver the electricity and cause some unwanted neurological side effects, not permanently, which is the great thing about DBS, but temporarily. And so those might be felt as some tingling or pulling of some muscles. And that's when you can modify the electricity to get rid of those symptoms and really focus on getting the beneficial stimulation in. So because that precision is important, I just sort of want to summarize again. You will have, when you have a good placement of an electrode and a good level of stimulation therapy delivered, you'll reduce that tremor and stiffness, especially during off times. You'll also improve that slowness. You probably will also make those dyskinesias or even dystonia, which is another sort of muscle posturing problem that people with PD can sometimes have. You can make those better. The problem sometimes is because everything is so tightly packed into that very critical area of the brain, some of the electricity might go over and stimulate areas that might result in a little bit of muscle pulling. This is often the face. You might get a little slurred speech or tingling, as I mentioned. And sometimes you can get even a little increased dyskinesia, but usually that's something we can manage. So that's why these are the good, the bad, but the adjustable. And having adjustable stimulation settings is important, not just in terms of how much to give, but where to give. And so that leads to innovation number one. This was approved in 2016. Remember that lead I showed you, there were 4 little contacts through which the electricity flowed. This would have been called omni or all directional deep brain stimulation. Now with the advent of some different leads, they now have sort of cut up these contacts into little segments. And so they call them segmented leads. And so you might, instead of just have one contact all the way around, you might have 3 at this level, and you might have another 3 at this level. It allows you to generate electricity that's, for example, one-sided. So then if you have your electrode sitting here, this is a very tight area where you really want to hit the sweet spot and not try to avoid those areas that will cause unwanted side effects. Instead of just a circular ball, you might be able to have a semicircle of stimulation, so to speak, and make your stimulation a bit more specific. And so now you have a bit more options should you need that. It turns out not everybody really needs this sort of directional kind of stimulation, but it can be a nice option to have. And so some clinicians have decided to recommend that for some of their patients undergoing DBS surgery. So the second reason, so I mentioned to you that there are ways for patients to monitor their therapy. Well, why would they need to monitor their therapy? I thought I was having this surgery so that I can forget about having to manage my symptoms so closely. Well, yes and no. And I think that is true for the most case. I think that DBS does what I look for, in a therapy that is going to really help my patients is for something that lets them forget a little bit about having to micromanage their therapy. So there are times though, however, and DBS largely does, I think, accomplish that, but there are times when situations will come up. So I've listed a few here. For example, patient might call and say, my tremor seems to be worse, and I don't know if my therapy got turned on or off. There's a way to do that. And sometimes people are not sure if it's inadvertently or accidentally turned off. Or I'm concerned my battery is running low and I want to be sure when I can tell when I'm due for a replacement. We'll talk about that in a sec. And then what if, my speech is affected by DBS, but it works so well for my other symptoms. I just want to be able to turn it lower just when I plan to be talking a lot. These situations can come up and might be good reasons for someone to want to be able to look at their therapy. Is it on? Is it working? Can I even turn it a little bit lower for a few hours? And the old programmer that this is not even really the original one, but the one that was more recently retired. This was from Medtronic, and I think there were a lot of pluses to it, in which there was a screen and there's some clearly labeled buttons with colors, but it was hard for people to understand. And I'm looking at this now and looking at the symbols and going, this is really hard to interpret what this actually means. A to B, and there's a doctor, and there's an arrow, and there's a B. So clearly something needed to change. And so what this looks like now, it takes advantage of the fact that almost everyone has a smartphone these days. And now you can use that to be much more clear about what is actually going on. And so in this photo here, you see that the battery to your DBS device is fine. It's totally fine. The one that communicates it might need a little bit of a boost, but it's generally fine. And the handset of this handheld device is totally fine as well. And so it lets people know very clearly what it is that they're looking at. And similarly, the other two companies have also come up with ways for patients to more easily navigate it. So this has really led to this innovation number 2, friendlier user interfaces. And these communicate with the DBS devices. This one is sort of homegrown from Boston Scientific. They've created their own, whereas Abbott has relied on the Apple system. So this is essentially like an iPod Touch, if anybody remembers what those are. It's not quite an iPhone, but it's pretty similar, except for the lack of the cellular service. And so now we have some things that are really meant to be a little bit friendlier for patients. Okay, the third thing. So I mentioned DBS delivers electrical stimulation 24 hours a day, 7 days a week. It works hard. The batteries need to be replaced, though, at some point. Nothing can really power something for forever. And batteries can sometimes last only a few years now. And I would say, having been in DBS for the last 13, 14 years, we have seen somewhat a decline in some of the longevity of the batteries, and the companies are working hard to correct that. That being said, there have been some solutions that have been proposed for certain patients who are concerned about this. So first of all, what do I mean? So I mentioned these devices earlier. They sit just under the skin in the chest. Surgeon usually makes a clean incision here, makes just a little room for it and slides this in, and then it's all stitched up. Turns out that, and we're watching this closely, people are doing a good job of keeping track, but the average life now of a deep brain stimulation battery seems to be about every 3 to 6 years. And the replacement of the battery is not as involved as the implantation of the DBS electrodes in the brain, but it still requires about a 1 hour or less outpatient surgery under anesthesia. Fortunately, infections have been happening infrequently. Some of the literature supports it's probably happening about 4 to 5% of the time. And these can often be treated with antibiotics, close monitoring of the wound by the neurosurgical team. But even so, there may be reasons people may want to avoid having a surgery every 3 to 6 years. There are also other factors that play into how quickly that battery needs replacement. So we've been talking a lot about the subthalamic nucleus, the really tiny structure, the alternative area where an electrode would be implanted in the brain, that globus pallidus. It's a bit bigger, and sometimes people use more energy sort of to cover that area. So it may need, the battery may sort of wind down quicker in those situations. Also, so as a corollary to that, as a related to that, how much energy you use to stimulate to reduce someone's symptoms might play a role in terms of how quickly that battery depletes. And it turns out, whether tremor is particularly prominent seems to play a role in how much electricity, and therefore how quickly that battery may wind down relative to someone who doesn't have a really bad tremor. So so this has led to innovation number 3, rechargeable batteries. There are now 2 companies that offer this, both Medtronic and Boston Scientific. The rechargeable models might allow that battery to last now about 15 years or probably longer. They're both, still a little too new and too little used. I think we just need more data to know whether or not it could go even longer than that. But at the very least, from sort of the engineering models that both companies and the data that they're providing, it should be good for at least 15 years. So that means avoiding several surgeries to replace the battery each time. There is not that much data on the experience of these rechargeable batteries, but a little bit. From some of the literature that people have published on patients who use it, it seems to be in general that patients who choose it seem to be pretty satisfied with it. There have been some technical issues in the past which led to inefficient charging, meaning this device here that this man has got in this sort of collar that he's wearing has got to be placed right over that battery. And if it's not right on top of it, sometimes it just is really slow. It's sort of like a faulty connection that you have a bad cable that you're plugging your smartphone in at night. It might not charge as quickly as a nice fresh cable and battery block. So that's sort of an analogy you can think of there. And so what happened was some people spent a lot of time charging per week and didn't like that. And so there have been some attempts to try to make this much more efficient. And both companies are working on this. Interestingly, there's another condition called dystonia, which is a condition in and of itself that's not PD, even though PD patients can have dystonia. That's a different disorder, usually happens earlier in life, and we can also treat that with DBS. That tends to take a lot more electrical stimulation. And so a lot of those patients will opt for the rechargeable. And interestingly, that group as a whole tends to find recharging more satisfying than people with PD. So the fourth and last thing we'll talk about is how complex programming can be. It doesn't always have to be, but it can. And it can take several visits to achieve sort of the optimal control of symptoms. So as I mentioned to you, I talked earlier about surgery to get implanted. And you get the hardware placed and you actually come back to the clinic where the neurologist will run through a few different options systematically on that electrode to find the right settings to stimulate to get optimal control of your symptoms. But there have been scientists and engineers hard at work to think about what if clinicians didn't have to go through that painstaking labor of systematically testing and having patients come in repeatedly to kind of get the right settings. What if we could use the information from the electrode to listen to those neurons, try to interpret what they're telling us about how the movement disorder is currently behaving, in a person, meaning these electrical signatures, we might be able to interpret them as telling us how dysfunctional the movement circuits are in the brain. And if we can listen to a few neurons this way, could we listen to thousands of neurons? And what that is called is a local field potential. It's sort of the summation of all that neuronal activity. And what can we learn from this kind of electrical activity that tells us about human movement and tremor and rigidity and slowness? And then just taking the electrical signals and coming up with stimulation settings that would actually be effective for that person with this particular type of electrical signature. So this is definitely in research phase in terms of understanding what these neurons do, but the technical capability of at least listening to some groups of these neurons, that is here. That is achievable with the so-called sensing DBS, where some of the electrodes, made by the companies who have this can actually be sort of even displayed, such that you can see some of this activity represented in a graph form. And what scientists at companies and universities around the world are working on is how would we create a DBS system which then automatically takes the information and chooses the settings so that a neurologist or a patient doesn't have to keep adjusting it. And a good example of something like this that's been done in medicine is something like a cardiac pacemaker. It certainly senses how the heart is beating at a given moment in time and sends out impulses to correct it. Or the same is true for a defibrillator for people with bad heart disease, and the heart rhythms can be dangerous and they need a shock to reset the heart. That's another example of how sensing could be used in a medical application. Finally, another way to maybe make programming visits easier on patients could be remote or telemedicine programming on the horizon. Even before the onset of COVID this year, where it's moved a lot of our healthcare interactions between doctors and nurses and patients online and on the phone, even before this, there was work underway to see whether or not DBS programming could be done remotely. And one of the places in the world that really needs this sort of thing is China. China is a huge country with vast geographic distances separating patients who really need a particular therapy and the physicians who know how to give it. And so there's a company in China called PINS that have published some of their work pioneering remote DBS programming in China, where a physician sits in front of a laptop, sends in some information to a server. A server is really just basically a station by which they can also communicate between the patient's computer or TV with a camera so they can see the patient. And then that sends whatever the physician puts in terms of the DBS programming stimulation settings, that can get communicated through Bluetooth directly to this little battery, which is sitting right in the patient. And so this enables, in these situations, a clinician to actually make some of the setting adjustments while the patient is sitting somewhere else, could even be hundreds of miles away. And that's very different from the current situation where people come into the clinic and the clinician sits in front of them and changes their settings using the handheld device positioned very close to their body. But a final thought on technology, while these technical advances are brilliant and have taken years of sweat, equity, and money to make them happen, most important factor is probably not the technology itself, but it's human beings helping make good decisions with you and helping you apply that technology wisely. And I think this is, probably one of the things we all recognize in our daily lives with technology with respect to whether it's healthcare, but other things as well in our life. And I think the situation is no different here. So with that, a few final words. Multidisciplinary teams are so important. The reason I have been so interested in taking care of patients with deep brain stimulation, I think that it takes a lot. And I really, try to think about what a person with PD is going through when they're really thinking about, gosh, where am I now with this disease? Am I managing okay? Should I really consider something like an advanced therapy or deep brain stimulation to undergo this, given where I am now? And it's a big decision, and I think it shouldn't be made alone. I think if you're lucky to have available to you, or let me put it this way, I think we should really encourage patients to feel empowered to go find the team that will help them make some of these decisions. And it could be the movement disorder specialist, but it's really just one person out of a team that should probably ideally include people in rehabilitation services like your physical therapists, occupational therapists, speech therapists, your primary care physician should play a role as well as other subspecialists, depending on what other medical conditions you have. And nursing, whether it's through the primary care physician's office or the neurologist's office. And psychosocial support is so important. Cognitive evaluations, mental health evaluations, social workers, psychologists, and finally, in playing your own role in determining how much and what kind of exercise and wellness activities you do. I think these can all play a really substantial role in how well DBS goes. And one tip I would say is to ask to talk to people who have gone through DBS who are willing to share their experience. My experience is that many folks are willing to talk and share the good, the bad, the ugly, and whether they would do it again. You don't need to write this down. This will be available later, but there are some excellent resources online. Here are some of the few I recommend and some of what I used during this talk. And with that, I will close it out and open it up for questions. Thank you.
Thank you, Doc. Great job. Thank you so much for your presentation today. I have a few questions for you. And for all those participants, if you have any additional questions, just get them either in the Q&A or the chat, and we'll try and get through as many as we can. One question that we have, Doctor, is how long does it take to be screened for DBS?
Yeah, you know, in an ideal world, a lot of times, you know, we can get this done, you know, I would say within, on average, 2 to 3 months. I think that one thing I'm finding as I go along with this is we should be, quote unquote, screening people throughout the course of their disease, meaning if you need that physical therapy assessment, why wait till you're thinking about having DBS to have it? You could have it sooner than that. And that can be incorporated into some of the decision making. You don't necessarily need to have waited until that point where you're about to have DBS. The same is true for cognitive evaluations or even mental health evaluations. So that's my long answer to supplement that short answer.
That's great. Another question is, does DBS have much effect on balance?
That's really interesting question, and something that, you know, I think we don't fully understand, but some of us are very interested in learning more about. For the most part, there are probably some subtle effects, and in some patients, I think that gait and balance is a complicated story, and it's not just simply due to on or off time. And we know that DBS can help speed you up, so to speak. And if that's what you need to make your gait better, then and if also that's what you need to sort of keep your balance better, then it will help. But in other situations, it may not help. And so that's why I think a really specialized PT assessment by people who know Parkinson's disease is really important for this.
Thank you. Another question that we have, do the benefits cross over to non-motor symptoms? For example, if people's physical symptoms are relieved, do they tend to have less anxiety, insomnia, etc.?
Yeah, it's a great question. And I think we're seeing the best data that we have for this is there is a global sort of quality of life score that have been used in a lot of the clinical trials. And we tend to use them clinically as well, just to get an overall assessment of how you think you're doing in all the areas of your life related to Parkinson's. And by and large, yeah, the clinical trial data show that that is improved. I will say one thing, I think one of the things we know as clinicians is that the folks that are in the clinical trials for whom we see really good results, we have to kind of extrapolate that information because the person sitting in front of us might not exactly be the same kind of person that was in the clinical trial. And so I think that it's important to say that if you're thinking about whether on the whole DBS helps these things, yes, I would say there's a lot of evidence for that. But you, in your particular situation, it will need to be sort of discussed and evaluated with your healthcare providers.
Thank you. Another question is there a window of time during the disease progression where DBS is most effective?
Yeah, it's a great question. I think this is a little bit of what I was touching upon earlier, which is, one thing a lot of us who see patients who are thinking about DBS wonder about is, um, would it have been better if this person showed up in my office about 5 years earlier? We know that Parkinson's, it can take a toll on other things, including cognition and some of the gait and balance issues that medication nor DBS can really relieve. And so I think we are seeing more and more uh, practices leaning towards having their patients at least think about it earlier. I also think there's probably a subgroup of patients who start out kind of young with Parkinson's disease, and they're more likely to experience some of the particular motor complications that DBS is good at solving. And so in those two situations, I think the window probably is a little bit earlier than what we'd been previously thinking about as a community.
Another question is the cost of DBS surgery and whether or not insurance covers the cost of DBS.
Yeah, this is a great question. The short answer is yes, this is an FDA approved therapy. So Medicare is by law required to cover it, as are all the insurance companies around. And I've never had anyone rejected for it. As people are aware, our healthcare system and the economics of our healthcare system is changing such that I think it would be an important thing to hear from patients how much extra they're not extra, I should say, but how much their insurance companies are asking them to cover. Because I suspect it is a little bit, right? At least a little bit, even though it is predominantly covered by insurance. And so what we tell patients, which I know is can be frustrating, is they should really check with their own insurance coverage plan if it's a private insurance, just to see what proportion they might have. Sometimes there's a so-called 10% co-insurance, or there's a deductible you have to meet before something gets fully covered. So those things still apply in this situation. But yes, overall, this has been approved by the FDA and therefore Medicare covered.
Good. Another question is the new sensing technology currently being used in clinical practice or just in research? And if so, how is it changing the practice?
Yeah, it's a great question. So it is available in that the batteries that often are now being offered by Medtronic, one of the oldest the oldest manufacturer of the DBS systems, that is available as sort of their default battery. You do not have to turn on the sensing. And I would say at this point in clinical practice, there's not a clear advantage to having it on. I think people are sort of experimenting with it to see if it tells us anything about what a patient is experiencing day to day in terms of their fluctuations. But we don't know yet as a scientific and clinical community whether these signals lead us to better programming choices, which then lead us to better outcomes. I think that some of the research that will be taking place over the next couple of years will tell us a little bit more about that. But yes, if one wanted to get this kind of battery to have a graph of what their electrical activity looks like, one can get that. So I should also mention, you need to check if you're going to have surgery at a particular place with a particular neurosurgeon, he or she may only use one or two of these different companies. And so if choice of device matters a lot to you, you might want to ask about that before you decide to have the surgery there, because they might not actually offer the particular device you want there. We have been fortunate to be able to give our patients the full range of choices. And so, for example, we have Medtronic, Abbott, and Boston Scientific at our center.
Question we have is, What sort of effect does DBS have on changing medications or stopping, reducing medications?
Yeah, great question. So I think I have seen a variety of responses. Um, I think that anecdotally, I'm seeing that patients are a little bit earlier in their disease, and depending on how much they're on and what they're using it for. But in general, sometimes, we can reduce medications quite a bit. There are times when we don't actually reduce medications a lot, but we do make their offs a bit better and those dyskinesias better. So you have the range of responses. So I think that is something to consider. The tremor itself is interesting because some people's tremor is not actually all that responsive to dopaminergic medications, in which case DBS to control the tremor can really, and let's say that person doesn't have a whole lot of other need for the medication, just to really reduce the tremor. In that case, the DBS can really fill that need, and the medication for the tremor is not needed anymore at that time.
And how about the cognitive improvements with DBS? Can you speak to that?
Yeah, it's hard to say. Studying cognition turns out to be really difficult. To do a really proper assessment requires, and maybe some of you have gone through this, uh, like a 2 to 3 hour visit with a specialist, a trained neuropsychologist who administers computer or paper and pencil tests. So largely, the data have shown that after DBS, we don't see a huge deterioration in thinking. We don't necessarily see a huge improvement either. So that's good news, I think. In general, the DBS, we want it to be there for motor symptoms, and we know it's there to be effective for motor symptoms and not for cognitive symptoms. And we hope that it doesn't have a bad effect on cognition. However, in some patients, and probably those who maybe are a little bit more prone to cognitive problems already at baseline, we do see a slight deterioration, not a huge one usually, but there can be a measurable decline in some patients' cognition on certain tests.
Thank you, Doc. One more question, and then we'll transition to your last few slides. Has any research been done on having two leads into both brain structures?
Oh, yes. Good question. Yes, not a lot. We're talking about handfuls of patients, and there have been other brain targets that people have been interested in because of this issue of trying to alleviate gait problems, which are not addressed by either of these two targets I mentioned today. And so there have been very, very small studies. We're talking handfuls of patients in which people have tried to use simultaneous, let's say, for example, the subthalamic nucleus and something else called the pedunculopontine nucleus. It's not currently recommended. I think we just don't know really what advantage that would afford in general in terms of putting two electrodes. And by two, I mean two on each side, so a total of four. And the data really suggests that you should be able to use either one mostly interchangeably. So you don't need four to get a better effect than just the two. So with that, here is, I think, the last slide, just a reminder of what the APDA Massachusetts Information and Referral Center can do for you. The phone number is listed here. They offer a wide variety of resources, including referrals, education and support groups. In this time, much of it is virtual, which actually might make life a little easier in terms of accessing some of this information. And then some of the resources available in the whole state with respect to local classes, some of which might be done virtually, I think. These include exercise and movement classes, but also from a training point of view to educate other healthcare professionals about how to help care for people with Parkinson's disease. There's a bunch of training programs for those professionals as well. And I think that is it.
Yeah, I want to thank you very much, Dr. Shih, about great presentation today, very thoroughly done. Thank you for answering all those great questions. For all of the participants, we'll be sending an email out. This presentation was recorded, so you'll be able to share it with your sphere of influence. If you have any questions, please reach out to us. The repository for information on the APDA is on our website, APDA MA, and we look forward to connecting with you in the course of the next 6 months. Our plan is to do as much as we can virtually. This presentation is one in a series, so you'll be hearing about other presentations that we'll be doing down the road. Many of our programs and services have been shifted to virtual. And so if you have any questions or have any needs, please feel free to reach out to us. Again, I want to thank the entire staff as well as Dr. Ludy Shih for giving a great presentation today. Thank you.
Thank you all. Take care. Stay safe and healthy.